Good morning, everyone. Thank you for having me. So my talk will be a bit different. It's going to be fun. It's going to be controversial. I'm going to be quick because I only have 8 minutes in comparison to the previous 2 talks. So in a quick glance, tricuspid regurgitation, prevalence and prognosis. This is like a new publication showing the population-based study, including almost 14,000 of patients with heart failure with a different spectrum of ejection fraction with TR, almost ranging between 50 to 30% of these patients, depending if it's preserved ejection fraction or moderately reduced or reduced, they will have significant TR. And this will impact their prognosis. Up to 50% reduction in their survival in 2 to 4 years once you cross the line of moderate to severe TR. And this another systemic meta-analysis of 70 studies, almost 32,000 patients, and they found that TR is an independent risk factor for all causes of mortality, irrespective of the atrial fibrillation, MR, LV dysfunction, or pulmonary hypertension, or even RV dysfunction. And that's because it's carpet bomb everything in your body. It's going to hit your kidneys, your liver, your malabsorption, your lungs, and finally, even cognitive problems. And it goes very slowly and very secretively. You start with initial visceral congestion, and as you go forward in time, it will start to be persisting and then irreversible organ damage with diuretic resistance. And this is where comprehensive evaluation of patient with those presentations should be taken in consideration by identifying the phenotype, the comorbid and the risk factor, and the anatomy of these patients to prevent and interact with this case in the beginning before the progression of their problem. And this is by suspecting it, starting with an echocardiographer, and finally referring to a specialized consultant, either in heart failure or valvular heart disease, where he will have an early detection with the red flags that it's been shown. You will do the diagnostic workup, and you will optimize the volume sets, and then you reassess again to decide the course of management. And take in mind, lifelong treatment. This you'll be hearing in the upcoming 5 years a lot. And then you go with the spectrum according to the etiology, the hemodynamic profile, and keeping in mind what medication should be introduced, starting from SGLT2 inhibitors, the 4-pillar, and adjustment and specialized therapy. And here is the guidelines. If you see, we're just talking about them, and specifically in secondary TR, we only say class 2B, 2A. Why? Because the surgeons are very smart. They know the outcome, despite the risk, it's still not great. In hospital mortality can reach up to 8 to 10%. And this is another retrospective analysis of using patients using echo who went for surgery versus medical therapy after, propensity matching and adjusting, and they found no difference in long-term survival. So what? Well, if you want to understand it more, this is a tri-registry where they divided those patients, putting them in a tri-score risk to assess if they go for isolated surgical replacement or repair. Patient with low risk, if you go for a surgical repair or replacement, they will have a survival benefit. If they are in an intermediate group, if you go for a repair, they will have survival benefit. But if you replace, you might not get the survival benefit. And if they're high, just makes sense, the patient, because the underlying medical problems that they have, it will catch up on them before even this valve will catch up on them. And they may not have any survival benefit, but quality of life. Someone said quality of life. Here the interventionist drumming on their chest, putting their Judkin catheter on the side and say, we are here to be heard. We're going to invent a treatment for each and every one of us in this panel. Multiple trials came out, TriIlluminate, Bright, TriScend now, which is presented recently, all the Pascal's trials saying we are here to be heard. We're going to say stuff that nobody will understand except us. We will say RVPA coupling, it will be better, cardiac output will be better, will impact the patients. We'll improve the nutritional status of the patient if we get this TR with minimal risk cases. And now we have even the Tri-France, unlike mitral France, which is have an impact and say, patients are doing better, quality of life is better. And not only that, there is a signal of reduction in hospitalization. And in London Valve, multiple trials came out talking about the same thing. Patients are doing better, we are doing better with the parameters, quality of life is better, so things are going in our direction. So TR matters. It is safe. It makes patients feel better and happier, and it bears some hope for prolongation of life. Keep in mind, these trials, all of them in the range of 1 to 2, 3 years. So if we can't do it, let's repair or replace. This is what we have now in the market currently. Should we do it to everyone, all comers? And what about the timing? Should we get them early or maybe late or very, very late? This is what we have in terms of the data that is supporting us. It's very challenging. It's a difficult valve. It's difficult in terms of the assessment and the imaging, the quality, the surrounding structure, and the procedure itself. It's challenging. We have predictors. We have the traffic light sign that tells us when we can go for TEER and when we cannot go for TEER, when it's red and we cannot do anything, and maybe replacement will be the option. But again, replacement isn't that easy. EVOQUE have a conduction disturbance going with up to 14 to 17%, or even more than 20% now in the latest trial. We have a problem with valve thrombosis. We have a jailed lead, which is not benign. And then we have the exacerbation of LV dysfunction. When you fix the base of the heart, you might interfere with the compliance of the ventricles. And finally, we can see here, if you compare back to back, you will say, well, things are not going very well for the replacement, but bear in mind, we're just starting. We're just understanding it, whereas the TEER had the luxury of 5 to 7 years now in the market and later life. So, but there's always a message of hope. When you replace, you will eliminate the TR. They will do better because, and the functional capacity of the patient will improve if they survive whatever bleeding risk or PPM going on. It is challenging. It's not easy, and it's difficult, and it needs dedication. It needs a team of who are interested, who are into it. So when you put it in a more understanding, take a patient, detect, treat, try to prevent. If not preventable, then you go with if it's a low intermediate risk, you might go with the surgical arm. If not, you have the percutaneous option, which can go in all variety. This is from the Switzerland, from the Tricuspi group. So simply, you do your TR workup, you see the eligibility. If it's TEER, go for TEER. If it's not, you may go for replacement, which is orthotropic placement. If not, you can go for heterotropic. If not, I'm sorry, you cannot save everyone. So the moral of the story here, it's a syndrome of problems. It's going to hit everything. They are good and they're not good, those patients. So take the patient and treatment before it's too late. The land is still ahead of us. The journey is far from finishing, okay? So we have a lot of things to detect. So first of all, you have to detect, treat, prevent, and if not, then select your patient with the best option of therapy that you have. And with that, thank you so much for your time.